Well, welcome to Health Live at Seniors Today. We have here with us Dr. Abhijit Joshi, who is a consultant general gastrointestinal and advanced endo-laparoscopic surgeon at the Dr. Hiranandani Hospital in Mumbai. He did his master's in general surgery from the KEM Hospital under the University of Mumbai. After that, he completed his fellowship in basic laparoscopy, followed by a diploma in advanced laparoscopy accredited by the Society of American Gastrointestinal Endoscopic Surgeons. He has been in the surgical practice for over 20 years. Dr. Abhijit Joshi has held a faculty position as a lecturer in surgery at the University of Mumbai. He was awarded a fellowship in laparoscopic colorectal cancer surgeries in Belgium in 2011. His area of special interest is advanced minimal access surgery. He has performed thousands of laparoscopic surgeries to date and has published many original research papers and interesting case reports in national and international journals of repute. Dr. Abhijit Joshi loves traveling, hiking, bird watching, and Hindustani classical music. Welcome to Health Live, Dr. Joshi. How's it been in at the Hiranandani Hospital in this COVID period for you?
Oh, I don't know. I don't have words to describe. Actually, it hit us out of the blue, but we've been at it. We've been at the forefront right from day one, managing COVID as well as non-COVID surgical patients. And it's as I said, it's kind of become a very well-oiled machinery by now. So yes, it's been busy, to say the least.
It was a privilege to have you here with us, Dr. Joshi. As we know, colon cancer is fairly prevalent right now, and we would like you to take this session about colon cancer prevention therapy and beyond. Over to you, Dr. Joshi.
Sure. Thank you. Thank you so much for those kind words and introduction, Mr. Maheshwari. Shall we start now?
Yes, please go ahead.
Good afternoon, ladies and gentlemen. Greetings from Dr. Hiranandani Hospital, Powai, Mumbai. So our topic for today is colon cancer. In fact, I have extrapolated this into colorectal cancer because the rectum is also considered as part of the large bowel. So colorectal cancer, we will discuss various dimensions, different aspects and viewpoints concerning this type of cancer. So why should we discuss colorectal cancer? Well, we are not a hotspot on the world map as far as the sheer number of cases of colorectal cancer are concerned, but still we are the 8th most common. So it is basically the 8th most common cancer among our males and the 9th among Indian females. We should also discuss it and highlight it because it is preventable. It is one of those cancers which is preventable. Of course, not entirely, but to a certain extent. And it is also one of those few cancers which has an excellent surveillance program. So we should discuss this and we should talk about the surveillance program. Now, the colon, as everybody knows, is the large bowel, the large intestine. It is basically present in the perimeter of the abdomen. It has 4 parts. This is the ascending colon. It starts from the junction of the small bowel and the large intestine, then the transverse colon, the descending colon, and then the sigmoid colon. Sigmoid colon then opens up into the rectum. This is an endoscopic picture, an endoscopic image of a patient with a cancerous growth of the colon. So how does one get colon cancer? Well, like so many cancers, the exact cause is not known. But what we know is certain risk factors and very strong associations have been identified. Now, most cases of colon cancer are sporadic. A few are familial. And among the familial cases, there is a small minority of patients who belong to certain syndromes, genetic hereditary syndromes, such as the Lynch syndrome, which is also called as hereditary non-polyposis colorectal cancer. This comprises 5% of all cancers. The familial adenomatosis polyposis syndrome, which is about 1% of cases. And then there are some very, very rare colorectal cancer syndromes comprising of less than 0.1%. But a vast majority of CRC, colorectal cancer patients, are the sporadic patients. Now, these are some of the non-modifiable risk factors. age more than 50 puts you at a higher risk of contracting this. A personal history, a personal past history of colorectal cancer or colorectal polyps treated in the past obviously puts you at a higher risk of contracting it again. IBD, which is basically inflammatory bowel disease. Some of our patients have Crohn's disease or ulcerative colitis, which are the two types of IBD. These put one at a higher risk of contracting colorectal cancer. A family history of colorectal cancer obviously puts you at a higher risk than the general population. Race and ethnic background. This really again does not comprise us. It's very commonly seen in African Americans and Ashkenazi Jews. And of course, the inherited syndromes, which is again the last of the non-modifiable risk factors. The familial adenomatous polyposis syndrome, the HNPCC, that is the hereditary non-polyposis colorectal cancer, which is also known as the Lynch syndrome. Now, what are the modifiable risk factors? Obesity. One can definitely keep this under control. It puts one at a significantly higher risk of contracting colon cancer. Excessive smoking, chronic alcoholism, a sedentary lifestyle, diets, something which is very, very easily modifiable. Diets very rich in processed foods, red and processed meats, puts one at a higher risk of contracting colon cancer. Insulin resistant diabetes mellitus, that's type 2, not the insulin dependent. Insulin resistant diabetes mellitus puts one at a higher risk of contracting colorectal cancer. And people who have received radiation therapy in the abdominal zone in the past, for whatever reason, puts one at a higher risk of contracting colorectal cancer. Now, what are the signs and symptoms? Again, everybody knows cancer is an extremely deceptive entity. Although I have lined up a few common signs and symptoms, well, it may not cause any of these. It may yet, sneak into one's life. But a few of the common symptoms are a persistent change in bowel habits, consistency of stools, a recent but persisting change would be indicative. Hematochezia or melena, this is bleeding in the stools. Now, hematochezia, the word hematochezia is a medical term for fresh bleeding, when one passes fresh red blood, or melena, which is passing altered blood, either dark, tarry black blood or dark brown blood. Persistent abdominal crampy pain, discomfort, and of course the general symptoms of weakness, fatigue, and unexplained loss of appetite and weight loss. How do we confirm on suspicion? How do we confirm the diagnosis of colorectal cancer? Well, obviously an endoscopy, a colonoscopy with a biopsy confirms it. A contrast enhanced computed tomography of the abdomen and pelvis tells us whether it has gone to some other corner, remote corner of the abdomen. An MRI of the scan of the pelvis is particularly important in rectal cancer. It is in fact supposed to be the gold standard for evaluating whether the rectal cancer has gone beyond the boundaries of the rectum to the adjacent pelvic organs. And endosonography is also a very well-proven diagnostic modality in the surgeon's armamentarium. It also tells us about the penetration of the cancer, which most commonly starts from the innermost lining. It tells us about the penetration through the layers of the large intestine. A PET-CT, positron emission tomography, and CT is basically an amalgamation of CT, computerized axial tomography, that's X-ray radiation, and nuclear medicine, PET. So this basically is done for the entire abdomen, and it gives us basically hot spots and distant remote metastases beyond the abdomen. A serum carcinoembryonic antigen is a very simple common test, a laboratory test done from the patient's blood sample, which if the levels of the values very, very high, say 2 or 3 times the upper limit of normal, would be very strongly indicative of spread to the liver metastases. This is a picture which shows colonoscopy, flexible fiber optic endoscope, which is inserted by the gastroenterologist from the rear end, from the anal opening, through the rectum, sigmoid colon, and up through the descending, transverse, and ascending colon. So this is a direct magnified imaging of the inner lining of the colon as well as the rectum. This endoscope, colonoscope, has a working channel through which the endoscopist or the gastroenterologist is able to insert certain instruments, biopsy forceps, a snare which can basically take chunks of tissue from suspicious areas and then send it to the laboratory for a further confirmation of the diagnosis. So therapy, how do we deal with colon cancer once it is diagnosed? Before I get into the details, let's just look at this figure, the stages of cancer. As I said, it starts from the innermost layer of the colon and then gradually penetrates through the outer 3 layers. And that's how it is stage 1. Stage 1 is, the tumor is at a stage where it involves only the innermost layer of the colon. Stage 2 is when it has penetrated through the entire thickness, that is through all the 4 layers of the colonic wall, but it has not gone beyond the 4th layer. Stage 3 is when it penetrates and goes beyond the 4th layer. It may also adhere or stick on to some of the adjacent organs by contiguity. And stage 4 is where the tumor cells find their way into the blood circulation as well as the lymphatic circulation and then go to distant corners of the body. Now let's come to therapy. Endoscopy plays a very important role in therapy. Those fortunate few patients who get diagnosed in good time, who have suspicious looking polyps, which when the biopsy comes positive, the endoscopist can manage that. He can simply yank out the polyp through a snare and send it to the lab. If the resection margin is negative for tumor, the patient is practically treated. Other modalities, more recent modalities, endoscopic modalities to treat colon cancer are what are known as EMR and ESD, endoscopic mucosal resection and endoscopic submucous dissection. So these enable the expert gastroenterologist to endoscopically excise sessile non-pedunculated polyp areas of the colon, where in these situations or scenarios, the surgeon really does not need to enter the picture at all. Endoscopy also has a role in palliative care. What I mean by palliative care is if a patient of colon cancer during the diagnostic workup has been found to have distant metastases, a curative resection really is not possible for that unfortunate patient. And say, for example, if he has a very bulky tumor, which is mechanically obstructing the colon, then the endoscopist can put in a stent, something called a self-expandable metallic stent across the tumor, which then expands on its own and opens up the narrowed space, which enables the patient to eat and to kind of go through his daily chores and daily functions. Surgery, the role of the surgeon comes where the tumor has gone beyond stage 1, when it has gone to stage 2 or even stage 3. Traditionally, open surgeries for colorectal cancers have been radical hemicolectomies, the radical right hemicolectomy, the radical left hemicolectomy, the low anterior resection of the rectum, as well as what is known as the abdominoperineal resection. In the modern era, the laparoscopy era, laparoscopic surgeons have come into the picture and have kind of taken over most of the open surgeries with appropriate case selection. Of course, a stage 3 with a very bad adherence to the contiguity, by contiguity to the surrounding structures, or a cancer which is disseminated should not be attempted, but with appropriate case selection, laparoscopic radical resections are really the end thing concerning surgical therapy of colorectal cancer as of present day. Chemotherapy, everybody knows, is the medications given for cancer treatment. There are 2 types of chemo as well as radiation therapy. Radiation therapy really gives extremely poor results in colon cancer, but radiotherapy has a role to play in rectal cancers. Both these are of 2 types, adjuvant and neoadjuvant. So when I say adjuvant chemotherapy, it means chemotherapy or radiation therapy given to the patient, administered to the patient after the surgery. Neoadjuvant chemoradiotherapy refers to the chemotherapy or radiation therapy instituted before the surgery, prior to the surgery. So both these modalities have adjunctive roles in the treatment of colon cancer. This now brings us to the most important part, the prevention of, it brings us to the modifiable risk factors. A healthy diet, a diet very sparse in or depleted of processed foods, red and processed meats, avoidance of weight gain, an active lifestyle, regular exercise, limiting consumption of red meats, increasing veggies, increasing fiber, increasing fruits, avoiding excess alcohol consumption, quitting smoking, and regular screening and surveillance beyond a particular age. We'll discuss the details a little later. Surveillance. Now, surveillance, the word surveillance applies to those people or to those patients who have already undergone therapy, who have undergone treatment for colorectal cancer. This is for the initial period of about 5 years and sometimes even beyond, to make sure that the tumor is not coming back, or God forbid, if it is, to pick it up in good time for treatment. FOB means the fecal occult blood testing. This is a very simple routine laboratory test. The patients give a stool sample. Ideally, it should be done biannually, once every 6 months. And if the stool tests positive for occult blood, it should be repeated again and a third time. So if at least 2 or 3 out of those 3 times the test comes positive, it then means that the patient is a candidate for a colonoscopic visualization. The colonoscopy, of course, is an interventional test and cannot be performed very often, but should at least be performed once a year, and SOS more often as and when the FOB comes positive. The contrast enhanced CT scan of the abdomen is also advised to be done once a year for patients of colorectal cancer who have undergone treatment as part of the surveillance program. The serum carcinoembryonic antigen, again, a very simple test to do, can be done initially in the first year, 3 monthly, in the second year, 6 monthly, and then from then on till the end of 5 years, annually. An increase in the carcinoembryonic antigen over the baseline levels would mean a possible secondaries of a recurring tumor or a recurrent tumor to the liver. Now, what is the future as far as cancer, or in particular colorectal cancer, is concerned? So a lot of research is being carried out in high volume centers across the world. They are trying to find technologies that improve the genetic analysis of stool samples. So basically what this targets doing is to pick up a possible tumor even before the fecal occult blood comes positive. So if we find out some way of analyzing and picking up genetic material which can delineate cancer cells for us, this would be way before the FOB test comes positive. Also, researchers are looking at changes in the gut microbiome and are trying to identify specific bacteria that could potentially help screen patients of colorectal cancer. Now, these two obviously refer to the screening or surveillance. But what about therapy? Immunotherapy is the name of the game. It's the in thing. A lot of research is being done on immunotherapy. Basically, what immunotherapy means is, in some way, directly or indirectly, boosting the patient's immune system and making it fight specifically the tumor cells. And this is of great relevance in colorectal cancer. Now, there are 2 ways of doing this. Basically, directly stimulating or boosting the natural defenses of the patient, or creating or producing or manufacturing or making substances in the laboratory that are just like the immune system components, which can then simply be administered to the patient to directly act on the cancer cells or to help restore or improve the immune response of the patient against the cancer. Types of cancer immunotherapy, I apologize, it's a little cluttered, this slide. We'll really go through just the headlines. Checkpoint inhibitors, these are basically the group of drugs which take the brakes off the immune system. So it basically stimulates it to recognize and specifically attack cancer cells. Chimeric antigen receptor T cells, where these white cells, the patient's WBCs, are mixed with a special virus that makes the T cells learn how to attach, specifically to attach to the tumor cells. And then these white cells are injected back into the patient so that they find, attach to, and then kill the specific cancer cells. Cytokines, all of us are aware of, these are small proteins. They are used to stimulate immune cells to attack cancer, the cancer cells. Immunomodulators, these are a group of drugs which generally boost our immune system to treat certain types of cancer. Vaccines, we've all heard that vaccines always in relation to treatment of infection, whether it is viral or bacterial infections. But cancer vaccines are a big field under research today. As I've said, we usually think of vaccines as modalities being used to prevent infection, but there are some vaccines which are being developed to help prevent or treat cancer, including colorectal cancer. Monoclonal antibodies, again, are man-made versions by recombinant DNA technology. These are versions of our immune system proteins, but which are basically specifically useful in targeting cancer cells and attacking and killing only the cancer cells and not the normal organs. Oncolytic viruses, this treatment uses viruses which have been modified in a laboratory to infect and kill certain tumor cells. Mind you, many of these modalities are still in different phases of research. Trials are on. The final word is not yet out. And some of them, such as the checkpoint inhibitors, monoclonal antibodies, are already out and they are being used actively for treatment of some cancers. As far as colorectal cancer is concerned, immunotherapy applies to the patients with Lynch syndrome. Now, Lynch syndrome is also known as hereditary non-polyposis colorectal cancer. We've seen already in one of the earlier slides that this Lynch syndrome comprises 5% of all patients of colorectal cancer. And in Lynch syndrome, basically these tumors have many mutations. This is basically a terminology for the genetic makeup of the cancer cells. And this basically makes them extremely susceptible to immunotherapies. So immunotherapy for colorectal cancer patients belonging to the Lynch syndrome families is a big thing, is the in thing. I am primarily an advanced laparoscopic surgeon, so please indulge me in these last few slides. I would really like to talk about the role of laparoscopy. Laparoscopy is a passion for me. Well, the first laparoscopic procedure or the first laparoscopic surgery took place in France in 1987. That was a gallbladder surgery. Now a laparoscopic gallbladder operation is the most commonly performed operation in our country and throughout the world. In the early 1990s, cancer surgeons started performing colorectal cancer surgeries using laparoscopy, but that led to disaster. The early surgeons, they did fantastic resections. They could free the tumor. They could kind of separate the tumor from the surrounding tissues. But when it came to specimen retrieval, that is the removal of the tumor, you can imagine a closed abdomen and just about the 3 or 4 or 5 port sites. The operating surgeon would actually enlarge one of the port sites and remove the specimen. That would involve a fair bit of tug of war and kind of pull and push. And this led to port site metastases, which was disaster. Also, doubts were raised about the adequacy of resection. Laparoscopy in general, one of the prime benefits is cosmesis, less invasion. But I guess a cancer patient is really not worried about cosmesis. All he or she wants is to get rid of the cancer. So initially, there were doubts about the adequacy of resection, whether the laparoscopic surgery matches up to open surgery as far as the completeness of resection was concerned. Towards the mid-1990s, in fact, it was stopped. Laparoscopy and laparoscopic interventions for colorectal cancer came to a halt, ground to a halt, because of the phenomenon of the port site metastases. But as surgeons realized this, new enthusiasm dawned at the turn of the century. Specimen retrieval techniques refined. Laparoscopic surgeons started using trocar site or port site protection devices through which the specimens were withdrawn. And then over the last 15 years, basically, we spent refining and perfecting the laparoscopic techniques for the surgical therapy of colorectal cancer. Now, there are some very objective criteria to evaluate whether the surgery is complete. Number one, the tumor-free proximal and distal resection margins. How much of extra normal tissue or normal length or stretch of colon has been removed, and whether at the margins, proximal and distal, of the surgical specimen or the removed or resected specimen, there are or are not any tumor cells. Second, the circumferential resection margin. Third, the number of lymph nodes which are removed. So the world average, recommended world average of the number of lymph nodes to be removed in a radical surgery for colorectal cancer is minimally 12. Anything equal to or more than 12 is considered adequate resection. So these are some very objective criteria on the basis of which one can compare and evaluate whether the surgery is adequate or complete. Now, a lot of trials have taken place throughout the late 90s and the early 2000s to compare laparoscopy versus the open surgery. COST, COLOR, MRC Classic, these are some of the prominent trials. COST was the clinical outcomes of surgical therapy group, which was a trial in the US involving 48 high volume centers of colorectal cancer. It involved some 884 or so number of patients who were randomized into open and laparoscopic surgical group. And then the end results were compared. This trial was published in August 2004. COLOR is the colon cancer laparoscopy versus open resection trial study. This took place over 29 high volume centers, again in the US. It enrolled some 1,242 patients and randomized them into open and laparoscopic surgical groups. Again, the end results were compared. The MRC Classic, that is the Medical Research Council's conventional versus laparoscopic assisted surgery in colorectal cancer trial, took place in the United Kingdom. This was published in a conference in Melbourne in 2002. It enrolled 27 high volume hospitals, centers who were tackling patients of colorectal cancer, and it took in around 790 patients for this study, again randomized between the two groups. All of these high volume trials came out with the conclusion that as far as the objective criteria of the completeness of resection are concerned, laparoscopy stands tall, shoulder to shoulder with open surgery, to the extent that the National Institutes of Clinical Excellence guidelines in the UK have mentioned that with appropriate case selection and advanced laparoscopic techniques, laparoscopy is at par with open surgery as far as surgically treating or curatively resecting a colorectal cancer is concerned. I'm going to end now showing just a few photographs of some of our recent surgeries. This patient came to us with a tumor, a cancer, actually of the appendix and the early part, the cecum, that is the early part of the large intestine. This actually presented to us with intussusception. Intussusception is a phenomenon where one section of the intestine telescopes into the next section. And we did a laparoscopic resection for this patient. This is the last terminal part of the small intestine. This is the large intestine. And that's the appendix. And at the base of the appendix was the tumor. This is a specimen of a laparoscopic radical right hemicolectomy this patient has undergone. Just see how big a stretch of colon and the proximal terminal small bowel that we've removed. This is the tumor. The patient had a bulky tumor in the early part of the cecum, that is the early part of the ascending colon. And that's how the abdomen of the patient looks like at the end of the laparoscopy, obviously devoid of the large scar. The lowermost port site I have widened over here a little bit, and then using a wound protection device, we have extracted the specimen. This was a patient who underwent a laparoscopic low anterior resection of the rectum. So he had a cancer of the rectum. If you can see my cursor, it's pointing to the image is not of a very good quality. It's a little bit out of focus, but if you can make out, that is the tumor in the lowermost part of the rectum. And this patient underwent a laparoscopic low anterior resection of the rectum. So all of these patients, our average nodal yield has been around 20 to 24, whereas the world average that is required to call it a complete resection is 12. This is one of the last slides now, laparoscopic abdominoperineal resection. This patient came to me with a tumor. You can see the tumor area here, very close to the anal opening, that is the skin, the perianal skin. So I had no margin to perform a distal resection and then perform an anastomosis or a joining of the proximal and distal ends. In such patients, such unfortunate patients, I must say, where the tumor is very close to the anal opening, the patients have to undergo what is known as either an open or a laparoscopic abdominoperineal resection. This is the end point, the end result. The patient basically lands up with a colostomy, a diversion colostomy, and this is a lifelong colostomy. And these are the trocar sites. One or two more pictures. This patient presented with a cancer of the descending colon. We went in planning a curative resection, but because the CT scan showed that the tumor was restricted to its point of origin. But when I put in my camera, I realized that there were very multiple tumor seedlings or tiny metastases in different corners of the peritoneum. As a result, a curative resection did not make any point. And so we did a local resection, a palliative, what is known as a palliative resection of the tumor, and we came out. This is what a PET CT looks like. It's basically a combination, as I said, of the CT and the nuclear medicine technologies, and it basically throws up hotspots. So this is basically a hotspot in the right lower abdomen of this patient, and at surgery, this was the tumor, which basically threw that hotspot. And PET CT is basically a scan of the whole body scan, which either diagnoses or rules out distant metastases. That's a cecal tumor, cancer, adenocarcinoma of the early part of the ascending colon. And with that slide, I come to the end of my presentation. Thank you so very much, and a good afternoon to all of you.
Thank you, Dr. Joshi. This was a very detailed and explanatory presentation. I am sure I can already see that some of the questions that people have sent to us by mail have been answered. But for those of you who have questions, please put them in the Q&A tab. Just a request, as we've seen over the last few weeks, if you can mention also the age and gender of the patient, or of the person whom you have a query for. So age and gender are important. Please put your questions in the Q&A folder. Now, we have a question from an anonymous attendee who says, for the colorectal cancer, the patients do have severe pain in the stomach. I'm 74 years old, pure vegetarian. Which are the best vegetables you would recommend? I need of a doctor for food timetable.
The best vegetables?
That's right.
Oh, I don't think I would advise any segregation or differentiation between the different vegetables. All vegetables are good as far as the topic of the day is concerned. What should be avoided categorically are the red and the processed meats. All veggies are excellent as far as prevention of colorectal cancer is concerned.
Thank you. We have a question from Pallavi Kanoria, who says, for someone who has had colon cancer, should we do PET scan every 5 years? And I asked her what was this person's age and gender, and she mentioned 62 years female.
Well, one could, but most of the surveillance programs around the world, I don't think they mention a PET CT unless one belongs to one of those deadly genetic syndromes, the Lynch syndrome family, or the familial versions of the colorectal cancer. I don't think a PET CT is really necessary. The simple fecal occult blood testing, a regular contrast enhanced CT scan, and the colonoscopy, should the need arise, are pretty much more than what is necessary as far as a surveillance program is concerned. Once a recurrence has been detected, in any of these surveillance modalities, then yes, that is when the role of the PET CT comes in to pick up hotspots and distant metastases in different corners of the body.
Thank you. We have a question from Prashad Shirsagar from Vadodara, who says, what should be an ideal lifestyle to avoid the risk of the possibility of colon cancer? One of my doctor friends said that it usually occurs in senior citizens post 60-65. Is it true?
Right, yes, that is true. In fact, anyone on the wrong side of 50 is supposed to be at a higher risk as compared to the general population of contracting colorectal cancer. As far as the lifestyle is concerned, we've already discussed it. I will summarize it again. A sedentary lifestyle puts one at a higher risk, so a higher risk of contracting colorectal cancer. So an active lifestyle, lots of exercise, healthy food habits, avoidance of red and processed meats, eating lots of veggies, maintaining healthy bowel habits, all these have a role in prevention. Weight control and avoidance of addictions like alcohol and smoking also have a statistically significant role in preventing the sporadic version of colorectal cancer.
Thank you. We have a question from Sushil Kumar, who's 73 years of age. Can we have the lab test SCEA for diagnosing a cancer? There are no symptoms.
Serum CEA, or the serum carcinoembryonic antigen that I mentioned, is a lab test which indicates liver metastases. Liver metastases could come, or liver secondaries could come from any organ, any other abdominal organ, including the colorectum. So the CEA really, as a startup, is not really a very good screening test. He should ideally be undergoing, if he has no family history of colorectal cancer, he should be undergoing an annual check with a fecal occult blood testing. And if that comes positive, repeat it 2 more times. If 2 out of those 3 or all 3 are positive for fecal occult blood, he should then undergo a colonoscopy. That should be the right way forward. The CEA at the starting point is not really the right investigation. It is just basically used to evaluate or diagnose liver secondaries or metastases to the liver.
Right. We have a question from Gurdeep Sraw, who's asked, like a PSA and annual check, what tests to be included for CRC?
So we don't have it's a very good question. A PSA is such a simple tumor marker, simple blood test for prostate cancer. A lot of tumor markers have been studied, including serum CA50, 50. So these are known as carbohydrate antigen 50. So certain types of colorectal cancer, a small minority of colorectal cancers, the CA50 shoots up at the onset of the cancer. But really, there is no simple answer to this. There is no, in short, to answer this question, there is no equivalent tumor marker like what PSA is to CA prostate. We don't have any similar tumor marker for colorectal cancer as of present day.
We have a question from Sushil Kumar and a related one from Mr. Jagdish Mudliar. Sushil Kumar asks, also please elaborate on consistent change in bowel habits. And Jagdish Mudliar asks, what are healthy bowel movements?
Right. So yes, well, healthy bowel movements actually differs from population to population, place to place on the world map. In the Western world, where people consume a predominantly non-vegetarian diet, having one bowel movement at least 2 or 3 days is considered normal. Whereas in our part of the world, having 1 or 2 bowel movements a day is considered normal. So what is normal differs really from place to place, different corners of the map. Bowel habits meaning frequency. It basically allures or refers to frequency of bowel movements as well as the consistency of the motions. If there is a change, if the frequency has suddenly shot up or down, either ways, extremes, and the consistency of motions has either gone too loose or become too solidified, either ways, in either directions, means a change in bowel habits. If that change is persistent, then that individual needs to go and consult a gastroenterologist, who will then put him through a battery of tests, one of which will be a colonoscopy.
We have a question from Prakash Chatri from Bangalore. What is the first sign of colon cancer? I'm 63 and a diabetic and I have serious constipation issues. I have tried multiple treatments for the same, but no relief. Please advise.
Right. So, well, I wish medicine, or for that matter, cancer was that mathematical and that arithmetic, and perfect. We don't really, there's no such thing as a first sign of colon cancer. Again, this will depend upon the morphology of the tumor. Sometimes a patient who develops an annular or a stenotic cancer lesion presents as a case of acute intestinal obstruction in very dramatic situation. The patient has an abdominal distension, has had a bowel movement for the last few days, is vomiting continually, and is having crampy abdominal pain. That's one extreme presentation. In some other subset of patients, the first sign could simply be a lack of appetite, a reduction in appetite, a loss of weight, or in some cases, either hematochezia or melena, passing fresh red blood if the tumor is in the left-sided colon, or passing altered dark brown or tarry black colored stools if the tumor is in the right side of the colon. So there is no uniform standard one initial symptom really. It varies, it changes, it depends upon the morphology as well as the location of the cancer throughout the stretch of the colorectum.
Thank you. I think we have time for three more questions. This is from Major General A.K. Jain, who says, I have this problem of hyperacidity and acid reflux. I'm 178 centimeters by 75 kgs, otherwise fit with no bad habits, and I'm 74. No smoking, not more than one small drink per week. Non-veg, not more than once a month, if any. Yeah, so he has this problem of hyperacidity and acid reflux. 74 years old, Major General A.K. Jain.
Right. So, of course, it has nothing to do with the topic of the day, but I will obviously answer the question. He seems to be having hyperacidity and acid reflux. He needs to be, I presume, if these are fresh symptoms or new symptoms, he needs to be given an empirical treatment with what are known as the proton pump inhibitor group of drugs, the pantoprazole, pan-40, pantosids, the now commonly used anti-acidity medications. A short course, typically for about 10 or 15 days, he should use it empty stomach and then report back. If there is a significant symptom control, he should then taper the treatment down and stop over the period of the next week or two. But if his symptoms do not respond to this initial empirical course of proton pump inhibitors, then he needs to be investigated and evaluated. And the bare minimum, he needs to undergo an upper gastrointestinal endoscopy. This could show a significant hiatus hernia, and if medically fit, may require a laparoscopic surgical correction.
Thank you. Second last question for the day from V.K. Agarwal, who says, I'm 70 years old. Is prolapse of colon area symptoms for colon cancer? Has colon cancer got any correlation with PDH?
Prolapse occurs, prolapse basically refers to a prolapse of rectum. The colon never prolapses out. And a rectal prolapse is really a different entity altogether. Although what I mentioned in the first photograph which I showed among the surgeries, it's a phenomenon called as intersusception, which is basically like one segment of the intestine telescoping into the next. So any early polypoidal cancerous growth can actually be the lead point of this intersusception. So in a way, yes, intersusception is possible because of colon cancer, but not prolapse.
We have one question which has come from on Facebook. This is from Mr. Kundu, who says, could you please clarify more about cancer vaccine?
Cancer vaccines, yeah. So, yes.
Yeah.
Is that it? That's the question?
That's the question.
So cancer vaccines are really not in rampant use at the moment, but they are a big news. These are basically genetically modified viruses, which are being trained to specifically attach to certain specific types of cancers, the cancer cells, and then destroy their genome. So effectively killing the cancer cells. That's what cancer vaccines are about. Traditionally, we've talked about vaccines as agents to prevent infection, whether bacterial or viral. But cancer vaccines essentially are not for prevention, but are for therapy of the cancer.
Right. We have another question from Harsha Shangari, who's again on Facebook. Doctor, my husband is 68 years old, suffering from fungal pneumonia, taking voriconazole tablet from 3 months. Still, he is not well.
Fungal, I didn't get the second word, Mr. Maheshwari. Fungal pneumonia?
PHMONIA.
PHMONIA. I don't think this exists as an entity, not even in dermatology. Forget colorectal cancer surgery. So I'm at a loss to explain, to answer that question. I'm sorry.
If you're online, please, must be pneumonia then in that case.
Possibly pneumonia, which is where again I'm out of my sorts. I'm a humble GI surgeon. So I think the person they need would be a chest physician.
Yeah, I don't see the person online on Zoom. Otherwise, I would have raised this issue. Okay, there's an interesting question which is there, which is a little off the discussion over here. But once again, our friend from Trivandrum, Mr. Nayanan Ravindranath, says very good presentation, and so have a lot of other people said. I desire to know how many surgeries have you done, doctor?
How many surgeries? As in, well, I've done almost 5,000, and but not 5,000 colorectal cancer surgeries. If he's referring to around colorectal cancer surgeries, that's about the numbers closer to about 125. But I've done almost 5,000 advanced laparoscopic surgeries till date.
Sorry to ask you this question that he's raised. I know it's a little insensitive.
No, not at all. I'm very high. In fact, I saw the message. I was reading the question, and please do ask me the second half of the question as well.
Which is, are all these successful for cancer?
Yeah. No. Unfortunately, I mean, it depends what you mean by success. If Mr. Nair, is it?
That's right. Yeah, Mr. Nair.
If Mr. Nair is referring to me feeling that my conscience is clear at the end of the day when I go to bed, that I have done an adequate or enough resection, yes, most of the times, and that is because, well, partly because of the surgical technique, but more so because of the great cutting-edge diagnostic tools that we have at our disposal these days. So we are able to better select our patients. So the stage 1 and the early stage 2 are the only patients whom I take up for laparoscopic resections. So as far as the tumor resection, the completeness of the surgery, the number of nodes sampled, yes, most of the times I can say my conscience is clear. But if Mr. Nair is alluring to whether I manage to cure or them all the time, 100% of the times, just by surgery, no, by no stretch of imagination. In fact, the last photograph which I showed was a failure. Actually, I had promised the man that I would be able to remove his tumor and rid him of his cancer. But when I put in my camera, you cannot imagine my disappointment when I found hundreds of tiny 1 millimeter, 1.5 millimeter seedlings of tumor all over the abdomen. And these are so small that even the best latest generation CT scan machine is not able to pick them up. So well, I did perform a local resection of the tumor, but that is Mr. Nair by no stretch of imagination, a curative resection. So in fact, I failed the patient there and had to refer him to my medical oncology colleague for adjuvant chemotherapy. So definitely no success all the time.
Thank you, doctor. You've been so candid and amazing that you answered this reply to this question. And Mr. Ravindranath also says, awesome, doctor. Let God give you power to save maximum patients. Thank you, sir. And we have a couple of other questions. I think, I know we are at 5:50. but some of them are. So Upasana Jain asks, what is the fatal rate in cases of colon cancer?
The fatal weight, body weight?
Fatal rate. How many of them are not successful? I think that's what she means to say.
Oh, there's no uniform single solid figure or a single solid answer to that, because it just varies across the stages, the fatality, case fatality rate that she's asking about.
That's right.
So there's no data, or there are no statistics. There's no single solid figure that I can quote to you.
We have a question from Milan Mehta, and I think this is a question which a lot of people will be asking. Is my stomach stopped bloating once I stopped consuming wheat and refined wheat products? Can gluten-free foods be harmful in the long term?
I think excess of anything can be harmful in the long term. It's really a non-specific philosophical type of an answer. I apologize again, because I'm not a gastroenterologist, or for that matter, a nutritionist. But I think, in my humble opinion, excess of anything can be harmful. And yes, we do deal with patients with a lot of food fads these days. And we tell them all the time that a balanced diet should be the thing that should be followed. But so many times I get the feeling that I'm banging my head on the wall as I'm trying to tell people, but because every now and then we have patients coming to our outpatient clinics following some specific diet or the other. Anything but a balanced diet.
And the very last question, Doctor, is an important question, so I'll ask this. Is there a chance of recurrence even after complete excision or a complete surgical removal?
Extremely low. Nobody can say no, because recurrence recurrence depends on the histological type of cancer as well. So if I have been able to pick up a cancer in a patient, a colorectal cancer, at a very, very early stage, everything has gone off everything is hunky-dory. I've done a fantastic surgery. I am very happy. I am very peaceful at night, get a good night's sleep. Everything good, but on the histological analysis, that cancer turns out to have there are some histological criteria which a microbiologist or a histopathologist will be able to enumerate much better than me. There are some cancers, very aggressive cancers, very prone for recurrences. So even if those have been picked up, fortunately for the patient, very, very early, and have been managed surgically in a great manner, great fashion, you can never say the chance of recurrence is zero, because it still depends on the histological type of the cancer.
Thank you very much, Dr. Abhijit Joshi. It was a pleasure having you here. You responded to all the questions exceedingly patiently, and thanks very much for your presentation. It was a pleasure, as I mentioned, to have you here with us. Thank you very much.
Thank you so much, Mr. Maheshwari, and I really thoroughly enjoyed every bit of it. Thank you so much.